Buongiorno. Good morning, everybody. First of all, a very warm thank you to Professor Cittadini. Thank you very much indeed for inviting me here to Palermo. This is my first time to Palermo, not my first time to Sicily. You have a very, very beautiful place here. Thank you for the invitation. So my brief is to talk about fertility preservation and focus on the prepubertal children. I am an oncologist. I look after children with cancer, and with Richard Anderson, we have developed a program in Edinburgh since the mid-1990s of taking ovarian tissue from young patients, from pediatric patients. Of course, childhood cancer is actually very rare, and if we can just get, you can see that under 20 cancer is only 1% of the total cancer burden. But what, of course, is really important is that survival has significantly improved, such that when I see a patient, I know that patient has over 80% chance of being alive in 5 years, and an over 70% chance of long-term survival. And therefore, when we see these patients for follow-up, and we are committed to following up our young patients, fertility becomes a very important issue for them. They have fought the cancer, they've got over the burden of the treatment, but what they want to know is, can I have children? Will my children be normal? Will they have congenital abnormalities? So fertility becomes a very, very important issue, and it becomes very important to address this issue right up front at diagnosis, which is a difficult time for the child and the family. Is there a fertility deficit for young females who have been successfully treated for cancer? What do we know about this? Well, Richard Anderson and myself, with colleagues from Public Health, looked at, in Scotland, the population, 2 databases, the cancer database and the database for pregnancy. And we linked them. This was not an easy study to do. We looked at all ages up to the age of 40. We went back from 1981 to 2014, and we had over 23,000 young women in Scotland with cancer. And we wanted to find out, is there a pregnancy deficit for these young patients? And indeed there is. So here's the normal controls, and this is years since diagnosis, and you can see there is a very significant difference. The cancer survivors were about 38% less likely to achieve a pregnancy after diagnosis than women in the general population. And this is now in press with human reproduction. Where are the missing pregnancies? What are the diagnoses that particularly contribute to the missing pregnancies? Well, top of the list comes cancer of the cervix. Perhaps that's not surprising, seeing as the treatment very often will affect uterine function. Breast cancer accounts for the largest neck slice. Is that the treatment? We don't know. Or is it choice? More research required. And you can see a number of other diagnoses, Hodgkin's, and so on. Skin cancer. I don't know why. But these are where the missing pregnancies are. So there's definitely a pregnancy deficit. And when we look at it by diagnosis and over periods of time, from the earliest 7 years to the last 7 years of our cohort, and look for 3 specific diagnoses, Hodgkin's, leukemia, and brain cancer, it's really very interesting. So in Hodgkin's, so if it was normal to the normal controls, there is a very significant pregnancy deficit in the early years with Hodgkin's. But it does seem to improve very significantly in each 7-year cohort. Then it falls off, but that might be due to the young age of that cohort. So it does seem as though with Hodgkin's lymphoma, where the treatment is less damaging for fertility. What about leukemia? This is really quite remarkable, isn't it? A very significant pregnancy deficit which has not improved with time. Probably as a result of the treatment, the successful treatment for the teenage patients and older is bone marrow transplantation with conditioning with total body irradiation, and that is sterilizing. So this is the group of patients particularly at high risk that require fertility preservation before their treatment. And of course our brain cancer patients, again a very significant deficit, probably multifactorial, certainly probably treatment related, but we know also that they are less likely to make and sustain long-term relationships. And they have cognitive problems as a result of cranial radiation. So it's multifactorial, but there's definitely a deficit. So these are the options. We've been discussing the options, and for the female, for the prepubertal girl, as we've heard, the only real option is ovarian tissue cryopreservation, and it should be done before treatment is started. And the real breakthrough came from our last speaker, when in 2004, as we've heard, he announced the birth of Tamara in The Lancet. This was a significant breakthrough. We'd been taking tissue just like you since the mid-1990s, and here we had a live birth after orthotopic transplantation of cryopreserved ovarian tissue. And this was, as you've heard, soon followed by Drollmeyer's paper and then Klaus Andersen's. So it looks like it works. It looks like it works certainly for young women. We're going to review whether it's working for the prepubertal child. And you've already seen this, that published in the New England Journal of Medicine, over 130 pregnancies now published after ovarian tissue, cryopreserved, thawed and replaced. So it does seem as though in the adult woman that this is moving very closely towards becoming established. If there is a high risk of infertility and it's possible to do it, taking ovarian tissue seems to be successful, and it's moving very fast towards becoming established. But for the prepubertal patient, my patients, there are still some issues, I think, that need to be resolved. First of all, in our very vulnerable population of children, the relationship is different. These are vulnerable patients. Often you're dealing with clinical trials to try and cure their cancer, you're dealing with their parents. The child is not able to give informed consent themselves to potentially experimental procedures. So they are vulnerable. So if we think about our patient, here is Laura. She's 15. She has quite a long lead up to her diagnosis of Hodgkin's lymphoma, 6-month history of intense itching, pruritus of her feet, and then a 3-month history of fevers, night sweats, a bit of weight loss, and widespread, low volume, but widespread generalized lymphadenopathy. And here she is sitting in our teenage unit, a 2-bedroom unit on our pediatric ward in our children's hospital, looking anxious, but there's an option for a mother to stay with her, and she has access to games and videos and things. If we're going to think about, so this is her presentation, investigations, very nice PET CT showing that she has disease all over the place, really, in the mediastinum, spleen, para-aortic, but most importantly, she has involvement of her pelvic bones. So she's got stage 4 disease, it was biopsied, it's Hodgkin's lymphoma, and I know that she has a very significant chance of requiring not just chemotherapy, but radiation to a field that will include her pelvis, putting her at high risk of premature ovarian insufficiency. And yet we expect her to survive. She went into a trial. I am proud of this trial because it's a European-wide trial. Euronet Pediatric Hodgkin's lymphoma C1, eligibility up to the age of 18, 2 questions. One was a radiotherapy question. Can we actually avoid radiotherapy for up to 50% of our patients? Radiotherapy plus chemotherapy being the standard option, standard treatment, gold standard treatment for Hodgkin's lymphoma. Can we use PET scans and render patients PET negative after 2 cycles of intensive chemotherapy and avoid radiotherapy. But what I'm particularly proud of is that for those patients with intermediate and advanced stage disease, there was a randomization. Can we remove the drug procarbazine? This is the P of procarbazine. We know that procarbazine is gonadotoxic for boys and affects ovarian function in the long term. Can we remove it and safely replace it by dacarbazine with equal efficacy? So it's a randomized study with a fertility question, which is very exciting. And this study is now mature and just about ready for writing up. We showed that, yes, we can safely remove radiation in half of our patients, and yes, COP-DAC is as good as COP-DAC. So we can replace procarbazine with dacarbazine, but we don't know the full answer yet on the fertility question. That data is still being collected and requires maturation. So when we are faced with our young Laura, we have to think right up front. At the same time as putting her into that study, we have to think fertility preservation, because I expect her to survive, and I think she's at risk because I think she's going to likely get radiation to a field that includes her pelvis, which will compromise her long-term fertility window. So we have to think about what can we do about it, and for her, a 15-year-old girl, in my view, ovarian tissue cryopreservation is the right option. So we can think about intrinsic factors to her health status, is she well enough to have an additional procedure? Can we get consent? What about the extrinsic factors? Well, the risk of premature the predicted treatment. And as we've discussed at meetings before, sometimes you set off on a journey with a patient, slightly uncertain about how it's going to end up. You don't always know if a patient, for example, with leukemia, is going to have a poor response and require total body irradiation, which will affect fertility, but that's only for a minority. Most of our leukemic patients in childhood are not going to require radiation and are not going to have their fertility compromised. So the risk, this is the important thing, the risk is about the treatment that is delivered. It's not about the diagnosis. So low-risk patients can be Hodgkin's lymphoma patients with low stage, but our patient, Laura, who is likely to have pelvic radiotherapy, is certainly in the high-risk group. And in our service in Edinburgh, she meets our criteria for being offered ovarian tissue cryopreservation. So she went into the study, she received 2 cycles of OAPA and 4 cycles of COP-DAC or COP. This was her response assessment. It looks good on the face of it. That PET positivity seems to have gone, but actually she is still PET positive in her bones, unfortunately. So she requires radiotherapy as expected. And it's a big field that she gets. And she gets a lot of radiotherapy to different organs at risk. And it's actually very important to try and define the dose of radiation received by these organs at risk. And of course that can be quite difficult to do, because where are the ovaries? How close are they to the radiation field? What dose are they getting? And they move, because the treatment is delivered Monday to Friday for several weeks. So these are all quite difficult issues. But certainly ovarian tissue cryopreservation is the only option for our young prepubertal patients. And the question is, yes, they are, as we've heard with, they are ideal candidates. Prepubertal girls have plenty of immature eggs, so they are potentially ideal candidates for ovarian tissue cryopreservation. Will the prepubertal ovarian tissue restore endocrine function? And, most importantly, will prepubertal ovarian tissue restore fertility? So what do we know about that so far? Well, the first evidence came from Poirot when they reported a 10-year-old girl with sickle cell disease, and in 2003, before she went on to have a stem cell transplant, she had her right ovary removed and cryopreserved. At the age of 13, she developed premature ovarian insufficiency and requested return for pubertal induction. At the age of 13, that's a little bit late, to suddenly realize that you haven't gone through puberty, no breast development. So they put the tissue back, and within 4 months, she had some breast development, and with 8 months, she started menstruating. regular menstruation for 2 years post-graft, and normal breast development. So I think this case, published in 2012, shows the first restoration of endocrine ovarian function from tissue that was definitely harvested from a child prepubertally. The next piece of evidence came really from the Klaus's group, Klaus Yiding-Andersen's group. And this was a patient with cancer, actually, a 9-year-old girl with Ewing's. Again, intensively treated with a year's worth of chemotherapy, and she had radiotherapy. She had ovarian tissue cryopreservation before the treatment was commenced. She developed premature ovarian insufficiency and no pubertal development, but was in remission. So 4.5 years after diagnosis, when she was 13.5, they decided to return the ovarian tissue, not for fertility, but for endocrine function. They wanted to take her through puberty with that tissue. The graft went back in, but ceased to function after 19 months. So she had 19 months' worth of exposure to endogenous estrogen. And several years later, unfortunately, Ewing's is a very aggressive disease. She relapsed and died from the recurrent Ewing's sarcoma. And, that's a worry, isn't it? Could the relapse have anything to do with the return of that tissue in her for pubertal induction? Well, they examined the tissue very carefully and found no evidence of the marker genetic rearrangement that was present in her cancer in the remaining stored ovarian tissue. So it doesn't seem likely that the tissue that was returned was responsible for her relapse, but it was put back in for restoration, not of fertility, but for pubertal induction. Is this the right thing to do? Well, I'm not so sure. Induction of puberty with exogenous steroid hormones, either orally or indeed transdermally, is well established. Our pediatric endocrinologists are very good at inducing puberty in young girls with Turner syndrome with exogenous estrogen. The reimplantation of the ovarian tissue into what is essentially a very hypergonadotrophic environment is, I do not think, ideal, because they go very quickly through puberty, much faster than a normal puberty. And we would argue that this is a potential waste of a finite number of germ cells that should be saved, banked, if you like, for fertility later on. But what is important about these two papers is that they show that tissue from a prepubertal girl, when reimplanted, can work and produce hormone function. But the risk of relapse, particularly in hematological malignancies, is high. Although almost certainly didn't contribute to the Ernst case, it is a worry. So then it was in 2015 from Isabel Demistier's group that they reported the first live birth after autograft of ovarian tissue cryopreserved during childhood. Well, she was a sickle cell disease patient, aged 5, from the Republic of Congo, quite a complicated patient, onset of puberty age 10, but no menstruation. She had an autograft with busulfan and cyclophosphamide, so gonadotoxic treatment, because of a sickle cell disease from a matched sibling for the severe disease, and laparoscopic collection before that at the age of 13 and 11 months. So she went into puberty at 10. She did not have menstruation, and then just before her 14th birthday, she had laparoscopic collection of the whole ovary in October 2000, before she had this potentially gonadotoxic treatment. And at the age of 15, she developed premature ovarian insufficiency, started on HRT, and at the age of 25, ovarian tissue was replaced. After 5 months of menstruation, which continued for 2 years, she had assisted conception due to male factor infertility with her boyfriend at that time, but unfortunately no pregnancy. And then, at the age of 27, what did she do? She got a new partner, spontaneous conception with a new partner and a healthy male infant born weighing just over 3 kilograms. So, she's certainly the youngest patient reported, tissue taken at 13 years and 11 months. I don't think she was prepubertal, but certainly the first live birth in a child reported in 2015. And then, as Jacques has just mentioned, the most recent and most convincing case comes from Sarah Matthews and Klaus Andersen. It's been published just a few weeks ago. Successful pregnancy, not a cancer patient, but in a woman previously suffering with beta thalassemia following transplantation of the ovarian tissue. And what a story this is. The patient came from the United Arab Emirates. She had thalassemia. She had ovarian tissue frozen in 2001 in Leeds in the United Kingdom at the age of 9, prepubertal, before her bone marrow transplant because of her severe thalassemia. Then the tissue was brought to Denmark for replacement in 2015 and transplanted back. And then she went to London under Sarah Matthews and conceived after IVF treatment in the UK and gave birth in December 2016. So this is prepubertal tissue, frozen in Leeds, replaced in Denmark, and she conceived in London. Complicated case, but I think really the first really good proof that this works for prepubertal tissue as for fertility restoration. She did have POI, high FSHs before treatment. FSH is still quite high after treatment. AMH undetectable before she had her transplant. And then when the tissue went back, some evidence actually of AMH production. And she had a pregnancy with assisted conception. So I think it is a convincing case that prepubertal tissue, cryopreserved, can restore fertility. But we need more cases, and as Jacques has pointed out, we don't know the denominator, we only know the successes. What's about our own experience? We have our criteria, as Jacques mentioned. They're quite strict. High risk of premature ovarian insufficiency, age younger than 35, no previous chemotherapy or radiation, unless they were very young and just had very non-gonadotoxic chemotherapy. So we followed up our cohort. We've been taking tissue since the mid-1990s. I know this is a complicated slide, but essentially we have three groups of patients. We have those patients in whom we offered tissue cryopreservation and those patients who we did not offer. As per our criteria, a high risk, assessed at presentation, have they got a high risk of POI? So we offered it to 34, it was taken up by 20. We didn't offer it to this group. And this is our whole experience over that period of time of young girls treated for cancer. Accessible, we had 14 in the tissue in the group that had tissue taken. We had a small number in the group that were offered, but for various reasons did not go through with the procedure. For example, the uterine factor was important in one patient. And then we had our not offered group. And the question is, do the offered group, the patients that we offered fertility preservation with ovarian tissue prepubertally, do they have a higher prevalence of premature ovarian insufficiency when we go back and look at them? And the answer is yes, they do. A very significant difference. So this is the cumulative probability of not POI. And if we go to look at the not offered group, only one patient, to our knowledge. We need to go back and look at this cohort as they're maturing. This was last censored in 2012, so we're going to go back now and look at it. But in 2012, when censored, only one patient in the not offered group has developed premature ovarian insufficiency, whereas 40% of the offered group have already developed POI, and their median age at that time was 17, so they're still young. So it does look as if we're offering it to the right patient. If you look at the hazard ratio, 56 times more likely to develop POI if you're in my offered fertility preservation group. So the ovarian cryopreservation in our series was offered to 9% of our patients and performed in 5%. The procedure was safe and without complications, that is important. No patients in our series have yet asked for reimplantation, but they are young. And all patients who have thus far developed premature ovarian insufficiency were identified except one patient. So I think our Edinburgh criteria proved to be helpful in thinking about the right selection of patients at the highest risk of premature ovarian insufficiency. What are the ongoing challenges? Well, we need to provide fertility counselling up front to our young patients at a difficult time for them and their families. Often clinical trials need to be discussed. Investigations are being done, lines are going in, it's an additional procedure. Oncologists are not always confident about talking about ovaries and fertility. This is a difficult area for them. We've got a cryopreserved ovarian tissue from the right, I think, high-risk patients. We've got to define the success rate more completely of the procedures. It's very quickly becoming established as a procedure for some women at high risk, but what about children? We need more evidence. And of course, because of the risk of transplantation of tissue that could potentially be contaminated by hematological malignancy, we need to develop IVG and IVM as a safe alternative so that we don't have to put the tissue back through basic research. So thank you very much to my colleagues. This is a big team that we have in Edinburgh. You'll recognize this young man, smiling as always. I think he's next up, actually. David Baird was right there at the beginning with Roger Galston, and Tom is my colleague who's done a lot of the mathematical modeling. These are my pediatric colleagues, and I highlight Evelyn and Marie. Their work they're ovarian biologists. Their work in the laboratory is essential. So thank you very much indeed for your attention.
It's a pleasure.